So this is a structured Viva task assessing communication with patient, communication with colleagues, patient safety, and applied clinical knowledge. You are undertaking the gynecology list with your consultant. While you are operating, your consultant has been called for an emergency in the next theater. The case you are operating on is a 28-year-old patient with a 17-centimeter left ovarian cyst, which is suspected to be dermoid. You are doing open ovarian cystectomy. You noticed that the cyst is really adherent to the bowel, and while you are dissecting it, you suspected bowel injury. The examiner will discuss with you about the management of this complication. So it's expected to have a station which discuss the complication which can happen intraoperatively, including bowel injury, bladder injury, and ureteric injury. So this station is dealing with the complication of bowel injury. The first question here will be, what will be your immediate action? So in case of bowel injury, we really need to stop the procedure. So once we suspect that there is a bowel injury, we need to stop. We can't proceed, and we need to cover the defect with a clean towel, wet clean towel, so that we will not allow the feces to spread in the field, and though we will prevent spreading of the infection. So that's the first thing we need to do once we suspect a bowel injury. Sometimes if we suspect bladder injury, we don't need to stop the procedure. We can just call the urology and proceed until he comes. And sometimes he may allow us to finish our procedure and then he will take over. However, in bowel injury, he has to repair the defect first, because carrying on the procedure with bowel injury will spread the infection all over. Okay? So first of all, that's the first action here, is to stop the procedure, put a towel, and that will minimize the spread of infection. Second thing, we need to communicate with colleagues. Before I call the colorectal surgeon, I have to communicate first with the anesthetist. That's the first person you need to speak to. So once you suspect a bowel injury, we need to speak to the anesthetist, inform him that we are now facing a complication and our procedure may be prolonged. And also, any complication happens during the surgery, like bladder injury, bowel injury, ureteric injury, we need to give the patient antibiotics. So who will give the patient antibiotic is the anesthetist. So the first thing, we need to speak to the anesthetist, inform him that we are facing complication, and if possible to give the patient broad spectrum antibiotics. And then we need to communicate with the person who is scrubbing with us, the scrub nurse. Please, if you can provide us with more swabs, needles, instruments, sutures, suture material, and because we are now facing a complication, so our procedure may take longer time. And then we need to communicate with the circulating nurse. So the circulating nurse has to call our consultant, or at least to inform him, because he is doing another emergency in the next theater. If he can't come, he has to call another consultant to come, and also to call the on-call colorectal surgeon to come to do the repair. Okay, so that is the communication with our colleagues. Then coming communication with the patient. If she is awake, if she is not under GA, we need to speak to her, and we need to reassure her that in spite we are facing a complication, but we are dealing with it, and please don't be panic if you see lots of people coming because we called them for help. Okay, so that's our first action. So again, we need to stop the procedure, cover the area, communicate with my colleagues who are the anesthetists, give antibiotics, communicate with the scrub nurse to provide more swabs, needle, instruments, and sutures, communicate with the scrub nurse to call our consultant and call the colorectal surgeon. Okay. The second question here will be like, if your consultant and the colorectal surgeon came, what do you expect them to do? So first of all, they need to identify the defect or the injury and assess the extent of the injury. So, bowel injury can be, either caused by sharp uh, injury, like while you are dissecting with sharp, it can have a clean sharp cut, or when you do some diathermy, you can also touch the area and disturb and make a hole or defect in the bowel. So the defect can be either sharp or thermal. The thermal is the more dangerous because sometimes even if you repair this defect and later on the vessels may be affected and damaged, and sometimes this area will be necrotic and slough down and causing again another injury, or sometimes maybe fistula formation. So the defect or the injury which is caused by the diathermy is more dangerous than the clean one. Okay, and be careful because many of bowel injuries may not be diagnosed intraoperatively and is only diagnosed postoperatively. And if this is the case, if you didn't identify your bowel injury intraoperatively, your patient may go into a septic shock and maybe death as well. So it's very, very important, if you suspect that you are doing too much dissection or you suspect bowel injury, to examine the bowel carefully and see whether you have or no. So they will come and assess the extent of the injury. So the wall of the bowel itself is like starting from the lumen to outside is consisted of mucosa, musculosa, and serosa, right? So sometimes the injury is only involving the serosa, the outer serosa layer. And if it is just serosal abrasion or just the serosa, so no need to be repaired. Okay. If it is involving the serosa and the muscle and is not involving the mucosa, in that situation we can suture it with a single layer. Should be interrupted sutures and not tension. We call it tension-free sutures. So single interrupted layer with very fine absorbable suture, maybe 3O polygalactine or any absorbable suture. And be careful, we need to suture the line to be in a transverse position and to be in a perpendicular axis to the longitudinal axis of the bowel, so that we will not cause narrowing of the lumen. I'll just show you a picture for what I mean. Okay, so as you can see, this is the injury, and the longitudinal axis of the injury is matching with the longitudinal axis of the bowel. However, when we get to put the suture, we reverse the direction and make it perpendicular, okay, so that the lumen will not be structured. Okay, so that's if it involves only the serosa and the musculosa, we will do single layer suturing and that's it. But if it is involving the full thickness, then we need to do double layer closure with interrupted sutures. As you can see here, it should be double layered, and both of them will be interrupted, and with fine absorbable suture, maybe also 3O polygalactine or any absorbable one. So what if the defect is like big, or if it is like, caused by thermal injury? It is not safe to do repair like that. So what we need to do is called resection and anastomosis. So we will just cut, the sides with a safety margin of 1 centimeter here and there, and we'll take a wedge from the mesentery, and then we will re-anastomose them together. Okay? So the question whether we are going to consider colostomy or no. So usually colostomy is not the the primary thing we do it in bowel injury here. However, if the bowel surgeon see that the patient needs to have a colostomy, it should be a temporary one just to allow the healing. We call it loop colostomy, and usually we do recommend primary closure rather than having a colostomy and another surgery later on. If she has a temporary colostomy, it can be repaired within 6 weeks, and in that case we need to talk to the patient after the operation and inform her how to take care and how to deal with colostomy. So that's everything. After they close the defect, then we will proceed for our operation. And after that, what are the measures we need to do? We need to leave a drain. So any injury happens, including bowel injury, bladder injury, ureteric injury, we need to leave a drain. Okay? And after that, now we finish the procedure. We put the drain, we give an antibiotics, patient now in the recovery, and now we need to go and speak to the patient. What are the post-operative measures we need to do? So first of all, we need to go and explain to the patient about what happened. We need to apologize for what happened and reassure her that we have already identified the complication intraoperatively, and we given her the best care, and we sutured back, and that's a known complication which may happen. And also we need to do the duty of Condor, because if we see such adhesions and it is adherent to the bowel, we shouldn't proceed unless we are confident that we are not going to do bowel injury. Otherwise, we need to stay and call the consultant and not proceed. So knowing our limitation is very, very important for patient safety. So we need to do the duty of Condor for that, because if anything went wrong, we need to be honest with the patient. Okay? So what are the things or the paperwork we need to fulfill in this case? First of all, we need to do incident report. We need to debrief the patient. We need to document full documentation of everything regarding the procedure, regarding the injury, and regarding the post-operative care. And what are the learning points or the reflection from this station? So we need to, if the examiner asks you what you need to do, we need to tell him that we need to do a reflective practice in my portfolio, my e-portfolio. So I will reflect on it on my e-portfolio, and I'll try to not to be overconfident. I have to know my limitation. I don't have to proceed unless I'm really confident, So how to prevent bowel injury if you have a patient, uh, what you need to do, like, to prevent bowel injury. So first of all, I need to take a full history from the patient before going to theater, and do careful analysis of her surgical history. So if the patient having any previous surgeries may put her at risk of uh, bowel injury because of adhesions, especially if she has like midline incision for any reason. So that's very, very important. Then I need to assess the degree of complexity of the planned surgery. So if I am going to do dermoid cyst of 17 centimeter, I may expect that it may be amalgamated with all the structures around, okay? So I need to assess this will be a complex surgery, okay? Also, the patient selection is very important. If the patient is having high BMI, if the patient is having any comorbidity, so is not my case. We need to select the patient who can I operate on. And also, I have to identify my surgical limits. Okay, so what went well in this case? The things went well is that we recognized the injury intraoperatively. So it's very, very important to reduce the morbidity and mortality, because if it is missed in theater, and then the patient will suffer from like signs of septicemia and septic shock, and sometimes the mortality rates may be high in this situation. Okay, yeah. So that's everything about bowel injury. It can happen with any gynae surgery, so hopefully no one will face it as much as we can. And that's a learning station to know our limitation and help us to be careful while we are dissecting the adhesion. Thank you.